Welcome to Focus on Health, a series of educational programs highlighting current health issues sponsored by the School of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Professor of Nursing at Salisbury University and host of the program. Today's program is on the Peninsula Wound and Hyperbaric Center here in Salisbury, Maryland, located at Peninsula Regional Medical Center, and I welcome Dr. James Burns. You are the medical director of the Wound Center, and Beth Reid, you're an RN and program director of the Wound Center. So let's start with you, Beth. Can you give us an overview of the Peninsula Wound Center and
Absolutely.
How long it's been there and what are some of your primary services?
Sure. The Peninsula Wound and Hyperbaric Center, we're in our 12th year. We are solely focused on healing wounds that aren't healing from normal treatments or normal therapies. We focus on chronic wounds, but we do also treat acute wounds, those with patients that might have comorbidities such as diabetes or impaired blood flow. We do welcome them, but our focus really is on those chronic wounds that are not healing from normal therapies that they might receive with their primary.
12 years, that's a long time.
Absolutely.
I know, I felt like we should have done this show a little sooner, but you know, it's great because I'm sure it provides a wonderful service to the community. It's a specialized area, and I know, Jim, you wanted to talk about the prevalence of these types of wounds and why.
Well, yeah, first to define a chronic wound, what is basically there's four orderly stages that a wound will follow when there's no interfering effects. And those are pretty much the wounding event, which stimulates coagulation, which is followed by inflammation, then proliferation, and then remodeling of the wound after the wound is closed. So the any wound that falls outside of that category, doesn't follow those normal stages or takes too long, is considered a chronic wound. Typically after 4 weeks, most wounds should be healed. If it's after 4 weeks, there's a reason it's not healing. It could range from foreign bodies in the wound to infection to what Beth was talking about, comorbidities, diabetes, which impairs healing significantly, venous incompetency, venous disease, which also inhibits healing.
And that's when the blood flow doesn't go back to the heart as efficiently.
Exactly.
So you have swelling and chronic wounds.
Yeah, and the majority of patients we see are either fall into those two categories. They're diabetics or they're chronic venous disease, and there's a range of that, all the way from just telangiectasias, which are spider veins on your legs, to swelling, to skin changes, and then to the chronic open wounds that get larger and larger and larger until something is done about it. And a lot of people don't understand what the pathology is there, but with the technologies and with the training that we've had about these types of wounds, both diabetic and with chronic venous wounds, plus his surgical wounds and so forth, and peripheral arterial disease, it's a little easier to manage, to find out what's wrong, which is basically what we do. I mean, the body has a tremendous capacity to heal itself without interference. But when there's interfering substances, our job is to find out what's interfering, and if it's correctable, to correct it. And we follow pretty much a strict series of clinical guidelines in order to help us figure out what is exactly going on, starting with the blood flow. And the prevalence, to answer your other question, sorry for going on like this, but the majority are the diabetics and the and chronic venous insufficiency. Just give you a feel for that, there are roughly somewhere in the neighborhood of 30+ million people in the United States with diabetes, another 80 million pre-diabetic, which means basically by definition that within 5 years they will be overtly diabetic. On the other hand, with chronic venous disease, which is actually more prevalent, the incidence is ranged anywhere from 25 to 100 million people with chronic venous disease, and there's various stages. The ulcerations that we see in the wound center make up about 0.03% of that, which is still a large number. And the diabetics they estimate 1 in 4 diabetics will wind up with a foot ulcer in their lifetime. So you take that 100 million, or just even the 30 million we talked about, and take a quarter of those people, and they'll wind up with a diabetic foot wound. And another really frightening statistic to add to that is that 80% of all lower extremity amputations that occur in this country are due to diabetes. and diabetic foot wounds, not trauma, not run over by a car or a train or whatever. And then the worst statistic of all, which most people don't realize, is that up 45 to 50% of the diabetics who have a foot wound who wind up getting amputated are dead in 5 years.
Absolutely.
The mortality is incredible. It beats cancers.
And I know I found some numbers about there's close to almost 7 million people that have these chronic wounds.
Right.
So it sounds like this is really a tremendously needed area of specialty practice.
It's a very underserved
Yeah.
population. I mean, but it's growing. Can't imagine living with a wound in my foot for a year.
Right, I know, and
they
that
come
happens
see us,
quite a bit.
but we heal it.
Are the majority of your wounds in the leg somewhere? Or what about pressure ulcers? Do you ever deal with those?
Yeah, there's lots of pressure ulcers, and there's anywhere where bone comes close to skin. Back of the head, the ear, the shoulder, the scapula, the sacrum, the butt area, the heels, the knees inside, and depending upon the condition of the individual, whether they're stroke, whether they're paralyzed, whether they're paraplegic, quadriplegic, comatose, or what have you, will determine where that wound is and what's at risk. Because the entire every place in this body where a bone comes close to skin is at risk for a pressure wound.
And I guess not only diabetes, but poor nutrition is another contributing factor.
Yeah, for most pressure wounds are as a direct result of unrelieved pressure for a sustained period of time with poor nutrition and a person who's already in a catabolic rather than an anabolic state. So
That's fancy words. Explain what that means.
protein breakdown,
Right.
as opposed to protein buildup. All the bodybuilders out there will know the anabolic from anabolic
Right,
steroids,
right.
but there are not too many catabolic steroids floating around out there.
Oh, jeez. Well, and we know there can be serious consequences. You kind of alluded to it for wounds that aren't treated or once they get infected or whatever. So talk about that.
Well, just picture walking around with an open wound on your leg or your foot for a month, and you can't get it to heal, and it doesn't look like it's going to heal. The embarrassment and the change in your activities of daily living that would cause are tremendous. Now, amplify that by the larger wounds, and the individuals who have poor blood flow, the wound is larging all the time, they get infected, say, and there's an odor associated with it, they're embarrassed, they isolate themselves, your entire lifestyle will change. So the morbidity associated with that, social morbidity plus medical morbidity increases, plus the mortality can increase if it's ignored for a long enough period of time. Or there are other medical comorbidities that are along with, say, a nail in your foot and you have really bad blood flow down there. Well, that's looking at an amputation if something is not done quickly.
And that's
So-
common with diabetics because they lose the sensation and they often
Right.
don't know they have problems with their feet.
Yeah, that's one of the biggest reasons for a diabetic foot wound is diabetic neuropathy. They lose a protective mechanism to let them know that there's something wrong down there. So.
And those are the patients that we really try to use the advanced therapies such as hyperbaric oxygen therapy for them so that we can prevent amputations.
Yeah, that was my next question. If you can explain some of the therapies you employ, including the hyperbaric approach.
Basically, the company that I work for is called Healogics. We both work for. All they have done is spend their time figuring out why wounds don't heal, and they've developed through a consensus, the American Vascular Society, American Surgical Society, and so forth, and their own research and data collection, which is millions of wounds that they've collected and the data on those. There's certain commonalities as to why things don't heal, and some of the therapies are guided at doing that. It's a multidisciplinary practice where we need vascular surgeons, we need general surgeons, we need orthopedic surgeons, we need internists, we need endocrinologists to work with us to manage their diabetes, to improve their blood flow. We need dietitians to control weight. We need physical therapists to help people start moving around and getting moving again. So some of the basic therapies that we supply are, number one, we like to see people on a weekly basis. We get aggressive with these things because we know time is against them. Most of the time, by the time they show up, it's against them. Some of these people have had, a gentleman that we have currently has had a venous leg wound for over 16 years on his leg. It's been open. So, and those take a longer time to heal, so the quicker we see people. But in any event, we see them weekly. We do what's called debridement, which is a fancy word for cleaning the wound off. We have to get all the non-viable tissue, the dead tissue, infection and so forth out of the way. We utilize, we have lots of patients who have PICC lines with intravenous antibiotics at home. We have utilize special dressings up to the point of biologic dressings where there's cryopreserved amniotic membranes that we will use. There's reticular dermal. There's xenografts that come from bovine and fish sources that we'll use specialized biologic dressing depending upon the type of wound. After it's cleaned, all the way up to and including the adjunctive hyperbarics. Hyperbaric oxygen is an add-on. It's another tool that we have in conjunction with what we're doing in the wound center itself, with debriding the wounds and treating the wounds. So it's just another tool that we have that improves blood flow, inactivates bacterial toxins, improves your own oxygenation to stimulate new blood vessel growth, which has been proven to do. And there's actually 13, I'm not going to list them, 13 indications that Medicare will actually approve and pay for this. And it's quite an intensive treatment because it requires an individual to commit to at least 2 to 3 hours per day, 5 days a week for 8 weeks.
It's a long time.
For the hyperbaric therapy?
Yeah, the monoplace chambers that we have, we can pressurize them to about 2.5 absolute atmospheres, which is roughly equivalent to 46 feet underwater pressure in a 100% oxygen environment for 90 minutes with 2 5-minute air breaks where they'll breathe room air of oxygen instead. So, and it's been proven to aid as an adjunctive treatment after a lot of other treatments have failed to improve the situation. So. We have a lot of tools at our disposal. We just have to know how to use them and when to use them.
And the hyperbaric, I mean, the principle behind it is the oxygenation.
Yeah.
And the whole body is in there. And do
Yeah.
some people not tolerate that well if it's a smaller space?
Well, there are certain contraindications, absolute contraindications, people we can't put in the chambers. But most people don't meet any of those, and so 95 to 99% of people that we run across can go in the chamber. And the interesting thing is, even though there are a lot of risk factors to it, the biggest problem that we ever have is the same as most people who go scuba diving for the first time. They can't clear their ears, and so we have to teach them different Valsalva techniques. Sometimes we've gone to the route of calling up a local otolaryngologist, have them put tubes in the ears temporarily so they can be treated.
Because of that pressure,
Exactly,
you're saying.
yeah, because they can't clear them.
I mean, I think a lot of people remember the old-time hyperbaric chambers, and it's kind of interesting they've been, this concept is now being used.
Well, there are
wound care.
monoplace chambers, and then there's multiplace chambers, and we have the monoplace chambers. Bigger universities and tertiary care places that provide hyperbaric oxygen for decompression purposes for divers and so forth that are located along the shore lines. They have multiplace chambers, a lot of them, where they have to have, or they have very, very sick people, inpatient departments, where they have to have an attendant go in with them, and it's pressurized, but it's not 100% oxygen, so the attendant isn't at risk, but people actually have a hood on which contains the oxygen under the pressure.
So do you oversee the care of all the patients that come through as far as assessment and determining a treatment plan?
Right, yeah, we have to make sure, I have to assess this individual for their safety in hyperbarics, and nobody can be in the hyperbaric chamber unless they're, either I'm there or Dr. Thomas is there.
Okay.
So-
And the overall treatment plan too? For
Yes,
any patient
yes.
that comes in. Not everyone needs the hyperbaric
Right, no.
therapy. Some people are using other types of
Exactly,
treatments.
they get better without it. I mean, those are pretty sick people that wind up requiring hyperbarics. They're
A
fairly
lot of
specialized.
patients with wound care.
Yeah.
I mean, a lot of times they heal very slowly. You just have to stick with it.
It is, yeah. Many of them take months, if not a couple of years, to heal. But they've come to us with a wound that's been there for
Right.
about that long. So,
Because our goal is to try to heal someone in 12 to 14 weeks
right.
with advanced wound therapies.
Okay.
Yeah. We'd like it in 4 weeks.
So you strictly serve outpatient patients?
Right now,
not
yes.
people in the hospital
Right.
that are sent over. They are discharged and then they come to you.
Yes.
Correct.
And they can be self-referred too. They don't need a doctor referral
Right,
specifically?
yeah, most of them come through physicians, but we will absolutely accept self-referrals. Anybody who's in need of that care can certainly make an appointment. We'll evaluate them and determine whether or not our services are suitable for them, or we can refer them back to their primary care doctor to handle that situation. We're not in the business of trying to steal patients from
Right.
other specialties.
And I guess, do you determine, I guess you'd have to check into whether their insurance would cover the,
Absolutely.
the treatment plan? And most do, Medicare and, okay, because I
Absolutely.
think that's important. Most people think, oh, you have to have the doctor referral for everything,
Right,
or else
right,
it may not
right.
get covered under their insurance plan.
No,
And we definitely keep the access and the information moving with their providers as well. We keep them in the loop. I mean, it's
Oh,
really a
good.
comprehensive wound management team. It's like how we like to think about it.
Well, that's the big emphasis today,
Yeah.
is on collaboration.
Absolutely.
And working together. I know, Beth, you wanted to talk a little bit about the Healogic managed centers.
Yes.
And you all work for Healogic, and you're saying it sounds like there's more than 700 of these
Yes.
in the country.
So yes, even in Europe actually.
Okay.
But Healogics is a management company out of Jacksonville, Florida, and all their focus is on evidence-based practice of advanced wound care. So they know that there's a need for it out there. There's the specialty of wound care. That's what they do. They focus on the best products that are out there to use. How do we use them? Anything that's changing. And then my role is about really educating the community of the services that we offer for the patients, so that the providers know that we are part of their team. Because our goal is to keep you out of the hospital. We want to keep you at home. Everybody heals better when you're at home.
Oh, absolutely.
Coming to see us regularly. Providers, they have a lot of patients they have to see, and what it takes, the time it takes for Dr. Burns to provide the treatment isn't always really feasible in a primary care office.
Right. It makes perfect sense, really, the concept. Just one central place where
Yeah,
people can come
absolutely.
and get the advanced treatment. So,
And we try to educate to avoid recidivism, which is huge in diabetic population, as well as the chronic venous population. They tend to recur. But luckily, they know that they can just call us and come back again.
Yeah.
But
you'll take them back, even though
absolutely,
they may
yeah.
have...
And the quicker the better.
yeah.
The sooner they can get in, the better. Even a wound that a primary care doctor may have in his office that he just doesn't have time to see on a regular basis, and we'll be glad to see it. Those are we do well with those. We can re-educate the individual and make sure they get the proper treatment, or at least guide the primary care doctor. If they don't need what we have, we can at least guide the primary care doctor, and I send them recommendations in their notes all the time of, this is what we would do, these are the studies we would get, this is the treatment I would provide based upon the results of this study. So.
Well, evidence-based is good, and it
Absolutely.
sounds like a wonderful service you're providing to the local community. And I know you said most chronic wounds are those that are 4 weeks.
Yes.
So, and people can call and self-refer themselves. I know
Absolutely.
you wanted to get the number out.
Sure, it's 410-677-6605. And they can call and make an appointment. We will go and request all of their lab information, whatever stuff is from their primary care, to make it easier on the patient so that we're prepared when they come in. But you can definitely self-refer, but we will keep their physician in the loop.
And their first visit is usually very thorough, so it's going to take some time.
Yes,
Well, I mean, that's good. And you need to really analyze what's going on.
absolutely.
And look at the big picture and figure out the best course of treatment. And it just sounds terrific. And of course, it's right on the grounds of Peninsula Regional Medical Center, so
Yes.
it's convenient.
And we really try to get our patients,
for
if they call, we
Salisbury.
really try to get them in within 72 hours.
Oh, okay.
So again, we don't want them showing up at the emergency room with a wound when they could be seen with us in an outpatient setting.
And there's more information on the Peninsula Regional
Yes.
Medical Center
Yes.
website, which
Yes.
we'll also post that at the end of the
Wonderful.
program. So I want to thank you both for coming
Thank
in.
you.
It's just great to know we have this level of service
Yeah.
regarding wound care right here in Salisbury, and I really appreciate you taking the time out of your busy schedule to come
Thank
in.
you. Thank you so much for having us.
Yeah, we really appreciated coming over and getting the word out.
Great.
Absolutely. Thank you.
And thank you for joining us for this edition of Focus on Health here on PAC 14.